And so welcome to Pathway Pearls 2.0. What about the ADC and the DMP, which many of you who are on this call I know are already familiar with those acronyms, but some of you may not be. So the admission to discharge checklist and the discharge management plan. So that's what we're covering today, looking specifically at just those two pieces of paper within the COPD and heart failure pathways. So just before we start, just acknowledge all the different people that are involved in helping make these pathways a success, and they're listed here. And of course, all of you, they're on the phone, and all your teams back home. So our learning objectives for today, of course, are to describe what the difference with the ADCs and the discharge management plans are, explain how they fit into the actual order set pathway bundles, try to demonstrate how to accurately document among them and what to look at and what we're looking at for, first of all, for data collection, because it's all about the implementation scores for some of your teams right now, because that's how we're promoting, to get them to be used, but also about what accurate documentation that is useful for the patient, especially for the discharge management plan. And then identify which data that we are actually taking from both of those documents. And of course, we're hoping to come away with at least 2 pathway pearls during this presentation. So just a brief for those of you who are new, so those of you who are not, you can kind of close your ears to this or just refresh why an order set bundle. It really is the big wave across Alberta Health Services and many health systems pathways, showing to improve care, acute to primary, transitions to community. So in all, it reduces hospital length of stays. We're hoping to reduce rates of readmissions to hospitals and emergency departments. That's our biggest thing that we're hoping to achieve. And of course, all of that translates into decreased costs to the system and quality to the patient. So on the other side, improving patient experience, consistency of care, continuing coordinated care, from hospital to community and primary care, and of course the access to specialists in primary care in a timely manner. So for those of you who have not seen, this is the actual what the heart failure and COPD order set bundles look like. They come as a package. They are on the first 2 pages that you see there are the admission orders. They're actually the traditional physician order sets that the physician ticks off which items he would like to order, specific to medication, maybe oxygen, diagnostic testing. So those are all on those. Then the next piece is the transition to community care, and this is where not that physician orders are not important, because they are very important, and we're actually showing that using the whole bundle together is showing success, but actually because it's not always ordered as a bundle, sometimes staff are taking it on their own to start at the transition to community care because the first 2 pages were not ordered, that we're actually proving successes in the length of stay and the readmission rate, depending on which side you use. But the ideal is to use the whole bundle together, which does come stapled together as one. So within that transition to community care is everything that is on that admission to discharge checklist, and ideally, if everything done, it corresponds to just a conferment of check off on the discharge management plan that the patient, one final review with them before they go home, they're given it. It's the discharge instruction sheet to confirm that everything that they had done with them was reinforced and understood. Sorry, I forgot to mention the LACE worksheet is in there, and that helps to determine when that patient will be seen next, which corresponds directly to what is put on the discharge management plan as well. So those are the 5 components of the bundle. So like I said about the orders, here they are, the required admission signature. We know that any type of standardized orders reduces medication errors, adheres to best practice evidence. They can't remember it all to write it all. There's so much evidence out there that a physician can only remember, even if they're the best physician out there and doing the best they can. The average is around 60% that they can actually remember to write without having them written down in front of them to remind them. of all the best practice guidelines that they should think of when the patient is admitted. So that's why we're really firm believers in it, and that's why it's really good practice to try to promote pathway order sets. So the transition to community care bundle, that's the third page there. Everything on this is on that admission to discharge checklist. We just use that checklist to help the staff, the frontline staff of all disciplines, complete this transition to community care. It does not require a physician signature to initiate. It has everything from consults, referrals, patient education, discharge planning. It includes a risk assessment for risk for follow-up or risk of readmission, and then it has follow-ups on it. So everything on one page, which seems like a pain, but when you go through the checklist, it actually simplifies it because it actually divides it up. If your teams are doing it with a multidisciplined approach, it actually divides it up into disciplines and doesn't quite seem so overwhelming in the inpatient setting. So, starting with the first thing, the admission to, this is the COPD admission to discharge checklist. Many of you have seen this, so I've kind of broken it up into sections. The first sections is the number 1, 2, and 2 there, and that is the patient education material. Was it provided to them? Was it reviewed with them? Was the inhaler technique reviewed? Now, within the guidelines and within our teaching teams, everything cannot be taught at once to the patient. So it's really pushed that you give them these education material. But it's really certain things, there's certain key elements that actually need to be taught when in hospital and reinforced before discharge, and then reinforced into the community, and then with more support maybe from pulmonary rehab or from seeing their pulmonologist or whatever kind of education they get into after discharge is when the more detailed education takes place over time. So just to remember that for your teams, they're not meant to, nursing isn't meant to sit down and read the whole book to the patient. That's not what it's meant for. So that's the first part. The second part is the screens and consults, and that's from number 3 till 10. And same thing, there is, when we talk about anything from early mobilization, we actually have definitions of it. We have a data dictionary that goes along with this that tells teams what we're looking for and what their actual guidelines mean and what actually is meant to be done here. And so a lot of screens doesn't mean it's a consult to physio, doesn't mean it's a consult to OT. It's more about the screening, and then do they need a consult further to protect them and get them ready for discharge. And this is all stuff that needs to be started on admission prior to the discharge day. And same with discharge services. This patient may be on it already, so looking at what that looks like within your facility. And everyone has a different way of doing this. Some people, they want a referral, the PTs want a referral and every patient comes in. Some say, no way, we cannot handle that. Let's see what we are doing that can actually screen the person for frailty. Or are we doing something already within our facility that is screening the patient for frailty, for cognitive, for malnutrition, that we can actually use and then follow that and do the consult if it's a positive screen after that. So every one of you have every one of the teams that we're working with has a local improvement team that is working on each of these elements and how to handle them. And this is my biggest saying within all my programs: you do the best you can with the resources you have at hand. So one hospital isn't going to have the same resource as another. So you may do it in a total different way. It may not be the ideal way, but it's at least something better than we did last week. So that's the way we approach each of these. The last final part of the admission to discharge checklist is the at discharge, what to complete before the patient, just as the patient is getting ready for discharge. So it might be within 48 hours it started. So that's in reference to follow-ups, referrals, what kind of communication needs to be sent out to primary care physicians, to the patient's designated supportive living center, to home care, who all could benefit from knowing what we did in the patient or in the acute care setting that needs to know about it in community so that the plan of care continues on, that they're just not forgotten. And we heard loud and clear from the patient's voice that the biggest And we know too from readmission rate, the biggest time of readmission rate was within the first 72 hours. And, excuse me, and they hear that the support is not there as well. Caroline, I have this big fear that I didn't start recording. Oh, yes, I did. Okay, never mind. Sorry. Okay, so here, that is the admission to discharge checklist. And then the up at the top is more so, did you complete it? What kind of comments? Did you initial it to say that you completed? Because a lot of people, it is part of the charting that you did complete this. So it does not mean that everything has to be done on everyone. So within our data dictionary, we actually refer to what some scenarios could be for yes, no, not applicable. And so I'm sure you have many more, and our data dictionary is morphing over time because it's expanding from what we hear from the front line. So if the patient was just discharged and a week later came back in, like me as a frontline worker, I would put a line through the patient education and said, at bedside or family bringing in was just admitted last week, will reinforce, right? Whatever you want in there. So it's not, or else maybe the patient's palliative and none of this is applicable. Some of it will still be applicable, like discharge services, and some of it may be applicable, like watching inhaler technique, maybe, or whatever. But if they're palliative and some of it is not applicable, we realize that, and we don't want you to think that you need to do this on people that it is not applicable on. So it's just a matter of charting and saying not applicable, palliative, patient deceased halfway through the checklist, or whatever. It's just more so guidance for nursing staff, and I shouldn't say nursing staff, for all multidisciplinary staff to look at, to say, hey, did we think about this in this population of patients such as COPD? Because it's really important. It's best practice out there, evidence that if we don't think about this with them, that it really could impact their transition to home and their readmission rate. Breaking it down a little bit more, we have marked off the 4 arrows here, and that is the 4 main components that need to be taught, reinforced, and using a teach-back method with the patient, if possible. Of course, if the patient has dementia or whatever, it's a totally different story. And those are the 4 things that are actually proven that in hospital, if shown and if done correctly, and reinforced, it does make a difference for the patient. The other ones are important no's, but really too much information in an acute inpatient setting that is taught is actually, there's evidence against that it's not necessarily great for the patient as well. So that's why we really ask the staff to really look towards these, and it should be quick, easy teaching. So for instance, the adequate inhaler technique, we have some websites out there that just quick reference for your frontline staff. I know they have it on their, some people have it on their desktops, and I, for instance, have used this, trialed this with my frontline, because I do work frontline, and have witnessed where the COPD patient has said that they've done the right technique. I've done this forever, and here they're using the turbo inhaler, I can't remember what it's called now. And anyways, they are not breathing it for 10 seconds in and out, and there was just no consistency in how they're using the inhaler. So it's really important for your frontline staff to realize that it should be quick, should be easy for them and for the patient, because we know that frontline are overwhelmed as well. The next section, like I discussed, so prior to discharge, these I have it circled there, and it's review results where relevant and ensure appropriate follow-up. So of course, and use the appropriate discipline where you have it. So, you know, not everybody has PT or OT. So what are you going to do to screen the best possible way you can without having those resources available to you? And we definitely got tons of ideas that we can help you with that. So some keys for this area for early mobilization: review the definition. Like, there actually is a formal definition of early mobilization, what it means, because people say, well, that patient is like is bedridden or they're in a wheelchair, there still is a definition from early mobilization, which many of you know probably from COACT. So nothing different than that. Are they on the right medications? So the respiratory, so pharmacy, from their point of view, it may not be seeing every single patient, but it may be looking just at the LABAs and the LAMAs and the combined ones, all the new evidence out there for which inhaler should be used. Does that physician, have they thought about it? Are they being triggered to order the right? And I know that this is different from Edmonton or from rural to urban hospitals. So really just be mindful of that not all doctors can be specialists in one area. So they really appreciate the teachings from, or the guidance from pharmacy. And then looking at, so for instance, respiratory assessment. So are they already on HOMO2? If they are, it's a quick yes or not applicable or whatever you want to write, and just say already on HOMO2. We don't need to see them again. And then, but we do know that respiratory therapists, we've heard it loud and clear that we implemented this pathway, and they wanted to at least be informed of the patient admission. They didn't necessarily want to see every patient, but they wanted to know that that patient was in the facility, because here we're doing this pathway and they didn't even know, and it was pending. Like a lot of them are co-chairs within our facilities leading this project, and they didn't even know that they actually had patients within. So however you choose to handle that with your unit clerk, with your consults, or when Connect Care, about how you choose to handle that. Consult, if it comes in as consult, that's individualized to your site. And then the last part is the screening. We all know that for both heart failure and COPD, these screens are actually the probably in any diagnosis, comorbid, or not comorbid, I guess many comorbidities. Anybody that is in with multiple comorbidities, what I'm trying to say, I apologize, should be actually screened for these. And we're actually starting to see, we started this and we're starting to see a trend towards, this is probably going to be the future of screens for almost all patients, not just these population. Do they need these? If they're positive screen, can it be part of the patient admission that the patient actually answers 3 questions, which I know that some sites have already done that. So it's more so triggering the thought, have we even thought about this, maybe at rapid rounds, to discuss whether this patient needs it or not. Now at discharge, MedRec, completed. Was it completed? Almost all the times it is now, so that's almost a given. LACE scoring. We recommend starting it on admission, however you decide to action plan on that within your site. Some people, the nurses, are started on their night checks because most of it can be done prior to discharge. Some, the hospitalists are doing it. And then is it filled completely when it's done? Is it being transcribed onto the discharge management plan? What kind of risk this patient is for readmission? Number 13, is the discharge management plan completed, which AKA is known to many people as the discharge instruction sheet. Are we having to do 2 now? Because is our hospital making us do the general one plus this one? Is there a way around that? Can we discuss this? We've heard this happening at a lot of different places. So what can we do to make it easiest for the frontline staff and still provide the necessities for this certain population, that they have the actual communication that they need to keep them out of hospital? Pulmonary rehab. Not everyone's going to be a yes. It's a very small percentage that actually goes. So what is the criteria to actually refer them and within your area? And does the patient even want to go? Don't even get that far to refer them if they're saying absolutely not. So once again, a trigger for you guys to think about prior to discharge. And then about the follow-ups, about the 2-week follow-up to the family physician, completely individualized per site, and notifications. That's huge with transitions in care within every single community and zone right now. It's only going to be discussed more and more about what is the best way to do this, to provide that communication to the primary care provider and to the supportive living centers and to home care. And very often we hear home care say, okay, we didn't even realize they had all this done in the hospital. What can we do to continue with this type of care? So that is that was the admission to discharge checklist for the COPD patient. Heart failure is similar, so we'll be able to whiz through that one, but we'll go next to the COPD discharge management plan. So like I said, I am used to calling it a discharge instruction sheet from where I'm from, whatever you want to call it, but with the official name is a discharge management plan, and actually that official name is actually being transcribed into the heart failure pathway, and now we know it's being transcribed into the cirrhosis pathway as well, because they're coming out with that. And so it is something that terminology will be around for a little bit, or that name. So within it, the first part is activity and education, and it's just to reinforce. Now we have the handouts for check off here, so it's just to reinforce, did you guys give those handouts when at the very beginning? It's probably a clear cut check, 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 but sometimes, you know, as we all know, patients slip through and you realize you get to discharge and you realize, oh my goodness, they didn't even get the education package yet. So that's just your second chance to give it to them. And then the actual red arrowed areas are actually right on this sheet, are right under activity, the tick boxes. Practice breathing and coughing, body positions, and then under treatments, be sure to use your inhaler properly. Those are the actual key components to reinforce in acute care and then at discharge, and then as well out into the community about their key components to think about and to really get that down pat for the patient before they leave home. Then the next session is the patient voice. We wanted to hear from the patient about what they felt about the care they received because of this pathway, and we found that it's actually working. That we often are seeing nursing or whoever is giving the discharge management plan, we're often seeing at the beginning especially that they're checking off this, and they may be very much checking it off as the patient answers, and they're individually asking each patient, but really it's meant for the patient or the family members to do on their own. So whether you give the paper the day before or whatever, and then if they answer no, it's not a strike against nursing or whoever, it's actually your second chance to actually reinforce. So this is really an important piece to making sure that the patient's voice is heard, and that if they say, no, I don't feel confident using my inhaler, then there's something there that maybe we're missing in the education material, or maybe we need to think about what the format that we're doing it, doing the teaching needs to be revised. And then the last step is all about the follow-up needs, and you are all used to that. And even about the influenza, part of the order sets could be to think about giving their flu vaccine or the pneumococcal, which may or may not be in season. But it's more so about, did you discuss with them to check with their public health units to see when they next need it, when they have it done? Because a lot of facilities do not do it in hospital, although some do, and that's why it's included in the order set. And then we've got the checkbox, has this been reviewed with the patient and family, and then verify it was complete. Now, we have heard you guys loud and clear that a lot of people are not comfortable with putting their first and last name. Within Connect Care, we are not sure what this is going to look like yet, but we do say that if you're not confident or comfortable, your teams are not comfortable with putting their first and last name, which I get, and this should be changed, but we can't put up anything for changes right now because of Connect Care. So put your initials, just so that it was done, or have the patient sign it with you. Whatever you're used to doing with discharge management plans, just something to show that this actually was reviewed with the patient. The very last part is the risk of readmission, and that's low, medium, high risk, and that's based on the LACE risk assessment. And it's a little bit different on the heart failure because we actually consider the BNP, discharge BNP, as part of that risk and how fast they're seen in heart function clinics. And so really important to the family physician that communication is out there. Now, it's an automatic, we're trying to get within 2 weeks, and it actually has been happening from what we've heard. But we do realize that there's challenges everywhere you go with no family docs. Although with this readmission, it gives them an alert that, you know what, is there something more we can do to send something out to them? And I know that the North Zone, some of them, the Grand Prairie's thinking of the community paramedic program, they're at a high risk. Is there something that they can actually do to send out to the actual home prior to the patient being seen by the family physician to help reduce the readmission rate? So I went through those components already. Sorry, I did it on the big page, but this is just breaking it down. So a good thing to even this slide to use for your staff to show them the main components. The other thing that I didn't mention is provide the or the original plan to the patient, just like any discharge instruction sheet or discharge management plan, a copy on the chart. You want for legalities, you want a copy on the chart to make sure that it's shown that it was done, and that's nothing new. And then that is just a little more detailed look of the patient information, the teach-back approach with the patient, and the patient follow-ups as well. And I went through that already. Heart failure is very similar. We'll kind of whiz through this. It's exactly the same kind of thing. Education material, screens and consults, and same kind of screens and consults are in the evidence as well. They have a little extra area. They want to make sure the echo was done within the last 12 months and it's documented. And the chest x-ray was done on admission as well. And I think that's just because they really want to start looking at that on admission, that those are things that really should be looked into. And maybe, and I guess that we're hoping to prod at the physicians to ensure that, hey, did you think about this? Because this really hasn't been done for like 2 years and they're in with heart failure as far as the echocardiogram. The rest is very much the same except for the 48-hour BNP. Now, a word of caution that we heard last week, and because it says obtain BNP within 48 hours, it's on this checklist. The caution is that you still need a physician order. So if you're actually taking apart, so some teams, because they cannot quite get their physicians to order the whole bundle as a one bundle, which means all 5 components on admission. They're actually, when the patients are getting to the floor with a primary diagnosis of heart failure or COPD, some teams are tearing off the first 2 pages and starting at the transition to community page, as many of you know. Now, the only fear of that is within this BNP, there is actually not a ticked off physician ordered 48-hour BNP. So that's something that you would have to reach out to your physician, who's ever the hospitalist or whoever's taking care of the physician during the care, and say, hey, the order sets weren't used. Do you want this 48-hour BNP still done to help us with risk stratification for heart function clinics? So that is up to them then. So just a word of caution, because there was an actual incident over that. Other than that, the rest is completely the same, with the exception that the follow-up is also sent to our heart function clinic if the patient belongs to one. So that's that page. And then yes, so this is the education page in more specific, and those are the 2 areas that, like in COPD, that are the main things for the staff to go through with the patient, and that we hope the patient can walk away with being able to think about these things when they go home. So the heart failure management guide, which is the red, yellow, green action plan, basically what to do if they fall into those categories. It's reinforced in any heart function clinic as well, so that needs to start in hospital. And then the daily weight monitoring. We really stress that if able, the patient starts to do their own daily weights within hospital and records them as well in their own booklet within their education bundle. And actually, of course, then staff need to record it within their charting as well. So that's the 2 main components within the heart failure education that really needs to be pushed and with the patient. And then same thing with early mobilization, review the definition to the best of their ability out of the bed with how they can tolerate it. It's quite straightforward. This is the same as the COPD one, exactly, and so I won't review that. And you just basically, like I said, you do the best you can with what services you have within your hospital. And we are really starting to cover frailty screen more completely, and we have a session coming up on that. And within Connect Care, we're hoping to have it really narrowed down into what that may look like within Connect Care for not only these 2, COPD and heart failure, but other areas as well. And this is just the last part of the checklist of the heart failures, which is completely the same as the COPD. So the discharge management plan for the heart failure is exactly the same. with the same kind of activities, same kind of patient voice, the questionnaire, same type of follow-up, except for what their risk stratification is. So the LACE that you do, plus the algorithm that is done that uses the discharge BMP that is done within 48 hours of discharge, puts them into the low, medium, or high risk category, which then strategizes how quickly they are to be seen within the heart function clinic. And then that's when you tick off the 2, 4, or 12 weeks. Now, I know that many of you are saying, but our heart function clinics can't accommodate that. But we are looking at that as well. So this is all part. So if they can't accommodate it, that's something that we are going to have to prove after they've done lean, looked into their processes and looked on their end of cleaning up their referral processes and their referrals that are coming in from other than acute care. So that's all being looked at on a larger scale, provincial scale, with even the Edmonton, Calgary teams really on board with this for the semi-urban and rural heart function clinics as well. So we need that evidence. We can't just say they can't get in. We actually need that evidence. So some of you on your scorecards are actually picking that as a metric. Can they get in within that recommended time? And we're actually tracking with the heart function clinic when they actually did get in. So it's all done for a reason. So this is just more detail that you could use slides with, even with your front line, more detailed on how to complete the discharge management plan, patient perspective, and then making sure that it's signed or verified, or initialed, however your team wishes to do that. And then the white, if it's a carbon copy, that the white is given the patient can erase to the chart, or a photocopy one for the chart. This is what a completed one looks like. Chantal will be doing a session on data, I believe it's next week, and talks about what the data looks like. We are tracking data on these two sheets right here, the admission to discharge checklist and the discharge management plan, mostly because we all know that you guys, that competitiveness helps for implementation. So you guys are actually, we're giving scores for how good teams are doing this, and it helps too with you guys looking at your scores. Say it's like 80% in one area that, that the inhalers are taught at 80% of the time, but maybe the early mobilization is only not done only like 30% of the time, then you're looking back at it and you're looking to see, well, actually, we're actually doing it, we're just not documenting it. Or, you know what, we should be talking about that at wraparound. So you're replanning. It's like a PDSA cycle, continuously replanning based on the scores that we give you. So the scores aren't meant to be like vindictive or anything. They're meant to help you show your frontline teams that, hey, this is what we're doing, and actually we could do better, or we are doing better. We just have to make sure that we're tracking it better and documenting better. So that's what these are all about. And like I said, Chantal will go more into it next week. And I can't stress enough, the data dictionary has little details in there about what yes, no, what no means, what non-applicable means. And really, just the more you write, like on this one, it's quite detailed. The more you write, the better that we understand, because we don't mean to ever mark against you, as people feel sometimes it is. So that's that. We also have, just on our own, we made a checklist of our own of who the responsible disciplines. So when this was first shown to everybody, it was felt that this was only one discipline that this was pointed to. And many of you on the phone would probably say right away, oh my goodness, nursing can't handle all this. And it's not meant for one discipline. And the teams that actually do it really, really well are multidisciplinary local improvement teams that meet regularly, like every 2 weeks, especially during implementation in the first few months afterwards, to actually decide who's responsible for what, and who, maybe there's multiple people that can be responsible for something. And some of them have actually even taken that checklist, so this actual checklist, and color-coded it as to whose responsibility it is, so that that when you actually break it down, the elements, it's not so overwhelming on one discipline. And so we do have this sheet of paper, and we have it on our website. We have it on our SharePoint that is shared with all of you, that you can easily access if you're just starting up. This is an example of action plan. We have so many action plans from all of you handing them in. We've got a huge master action plan for every single implementation of every metric or item on that checklist. So we would be happy to, if you've never seen it before, we'd be happy to share with you. And then plus we will have a report out coming up. I believe it's in the end of June here, that where all our provincial leads get together and we share again some tips and tricks and some wins and losses and help to troubleshoot with each other. And that's coming up. That anyone actually can attend, but we require one person from every team to attend from the actual teams. So like I said, the PDSA cycle, plan, do, sustain, act, and keep redoing. And that is actually the presentation. That's the detailed presentation of those two sheets, the admission to discharge, ADC, and the discharge management plan. This is our support unit, pathway support unit that is available to help you. We really want to be helpful. We don't want to overwhelm. We've all been frontline before. We understand what it means when you say, hey, we can't do this, we're overwhelmed. So please just tell us what you're overwhelmed with and we try to troubleshoot the best we can. So Pathway Pearls, so I think I said it already, ensure multidisciplinary team approach, not just one discipline. It's not going to work that way. And not just one person running the whole team as well, or else that is the team, because that's not going to work at all. That does not sustain anything. And then the discharge management plan, it's really meant for the patient. It's to provide clear communication to the patient about key content necessary for successful transition to home. So really think about your patient when you're writing it. I know as a frontline worker, I've been there in acute care where I've just taken a discharge instruction sheet and tick, 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 Canada Food Guide, activities tolerate and everything, and never really thought about that this is for the patient and that the highest risk of readmission for most patients, no matter what disease they are, within the first 48 to 72 hours. And we heard it loud and clear from the patients as well at our last learning session that they feel completely lost for the first 72 hours. So that really, the more details you can provide in that plan, the better. And the more that it's communicated out to for people that can help them at home during that time frame, the better for the patient. So I will stop recording. Just give me a sec to figure out how to do that. And there is our Heart Failure Pathway email as well address. If you have any concerns, or just reach out to us at any time. And I'm going to stop the recording right now. And